Okay, great. Hello, my name is Annie Derthick. I am a psychologist and the director of behavioral science currently at the Central Maine Medical Center Family Medicine Residency. And I'm going to talk a little bit about agenda setting and a couple of other tips for time management and being more efficient during the course of a clinic day. I do mostly work with family medicine residents in the ambulatory setting. So most of what I'm going to talk about today really is meant for outpatient primary care. But I do think that some of the concepts and tools that I'll discuss are generalizable to many patient interactions. For my money, agenda setting is one of the things that you can do that has the highest return on your investment as far as time goes in the course of a time limited patient interaction. It does take a few minutes at the top of a patient encounter, but you get that time back in time saved over the course of the visit. Um, by setting an agenda at the beginning of a patient encounter, you have a little bit more control over how patient concerns come up. If something is important to a patient, it will come up. It'll either come up when you ask about it during setting an agenda, or it will come up as you're walking out of the room and have that infamous door handle item that comes up, as you're walking out and the patient says, by the way, um, I have, oh, it's okay. Thank you. It's okay. I'm good. Thanks. Um, by the way, sorry, somebody knocked on my door. By the way, I have something that came up and I wanted to chat with you about it as you're walking out the door. So it is really helpful to have a little bit more control over how and when and where those items come up. And so again, you get the most return on your investment spending a few minutes at the top of the encounter, setting an agenda. So in the outpatient setting, typically there is a lot that is pulling on your attention. There's the acute reason that the patient came in to see you, any chronic conditions that you might want to follow up on and address or that complicate the presenting problem, the ever increasing list of preventative concerns that you need to screen for, that list of USPSTF recommendations and all of the quality metrics that your organization might have that are always kind of coming back to the primary care provider. And then any behavioral health or mental health or all of those non-medical factors that tend to add complexity to the visit, whether explicitly or implicitly by complicating communication or that complicate the clinical presentation. And sometimes it can be very hard to decide what to prioritize in the visit or over the course of the visit. And so setting an agenda at the beginning of the patient encounter can really kind of clear the fog, so to speak, and give you an outline for what you need to really focus on, and then help you kind of refocus as things may get off track over the course of the visit. Creating an agenda allows you to do several really important things in addition to outlining how you're going to spend your time. It helps you orient the patient to the visit and to the interaction and really to the relationship overall. So I'm really a fan of this idea of role induction. I use it all the time. Patients don't always know how to be a good patient. Nobody gives them a pamphlet and says, this is how you can be a great patient and get the most out of your interaction with your physician today. They learn how to be patients through observing the clinic, by being shuffled through the process over time, and by their ongoing interactions with you. Um, unless you actually take the time to orient them to what to expect from this particular setting, what to expect from the visit itself, and what to expect from you as their provider. And every provider is different. And so what their experiences were with a previous primary care provider may or may not be reflected in what you would like their expectations to be from you. So one of the examples I use quite a bit is the fact that primary care appointments are time limited. They're usually 15 or 20 minutes or 30 or 40 minutes. And most patients don't know this. I started working in primary care and family medicine residency settings when I was in my early 30s. And I had no idea that a regular primary care appointment was 15 minutes long. I have reasonable health literacy, and I did have some vague awareness that they weren't very long, but I didn't know that they were 15 minutes. Nobody had ever told me this. And so when I started working with residents and somebody mentioned that these appointments were 15 minutes, I was actually shocked to learn that they were that short. And I had been to the doctor dozens of times over the course of my life, and it took kind of my breath away to learn that they were this short. I was like, what do you mean they only have 15 minutes with a patient, right? And I had been to the doctor so many times and had been the patient on the other end of this interaction, but nobody had ever once told me that this was a 15-minute encounter. The patient's experience of this time that they spend at the doctor is this. They make their appointment and are told to show up 10 or 15 minutes early. And if a lot of patients are like me, arrive 5 or 10 minutes before that time. So I'm sitting in the waiting room for 10, 15, 20 minutes before I get called back to my appointment. And that's just the rooming appointment. So the rooming appointment takes 15 or 20 minutes. Then I'm sitting in the exam room for 10, 15 minutes waiting for the physician to come in. And then the physician comes in and we spend our 10 or 15 minutes or 20 minutes together. And then I have to go up front and check out, which I might have to wait in line for a couple of minutes. And then I sit down and I make all of my follow-up appointments and then I leave. And so my subjective experience of that visit encounter is that it was an hour or an hour and a half. And it is my mental concept of how long a doctor's appointment is that it is an hour or an hour and a half. It is not that it is 15 minutes long. If somebody kind of sat me down and, walked me through that process, I could probably put my finger on the fact that I spent, 10 or 15 minutes with the physician, but that's not my subjective experience, right? And so in order to help patients really kind of consciously understand that this is a time-limited interaction, that there are some actual parameters around how long the doctor can spend in the room with them, this has to be explicitly stated. You cannot expect them to just put those pieces together for themselves. And the lower the patient's health literacy, the more explicit and the more frequently this needs to be done. The other thing that setting an agenda is helpful for is reviewing what you already know, right? Hopefully you are spending some time prepping for the appointment, reviewing the patient's chart. You'll also get a handoff from your MA or from your nurse. They'll tell you why the patient's there, what the patient reported to you. And then when you go in the room, you can review what you already need to know. You don't need to spend time having the patient report to you what they've already reported, what you've already reviewed in the chart. I do a lot of live observations with residents, and I can't tell you how many times I've spent, watching them review the chart, overhearing the MA give a handoff, and then we walk into the room and the resident says, "So what brings you in today?" And we spend 3 minutes listening to the patient tell the resident everything that the resident already knows. That's 3 minutes that could have been spent doing something else. When I ask the residents about this, why did you spend 3 minutes doing this? Oftentimes what they say is they want the patient to be able to share with them in their own words what's going on. And you can still honor that without spending that time having them tell you everything they've already shared. It also values their time in a better way, right? because they have already shared that information. So letting them know that the time they've already spent was important. I've actually seen patients get very frustrated about this and say, I already told so-and-so, don't you read what's in the chart? Um, so walking into a room and saying, kind of summarizing what you already know, and then asking them to fill in any blanks still honors, the opportunity for them to tell you in their own words. Then setting the agenda helps you prioritize how you're going to spend your times. You cannot cover everything. Um, and it's important for you to identify what is the most important thing, both for you and for the patient. And if there is some discrepancy between what's important for you and what's important for the patient, then you can negotiate between the two of you how you're going to use that time, and then make a plan for what you're not able to cover. And then, of course, you will need to interrupt if necessary. So this is how it all comes together. I like to provide scripts for my residents because I think it can be helpful to just have words to say to start to build some of those neural pathways. And you can use my words to start, but then as you practice, you can start to replace my words with your own and kind of find your own groove. But this is how you bring it all together. So orienting the patient. You can say, Jason told me you're here to talk about your back pain. Before we get into that, is there anything else that was important to you that you were hoping we could talk about today? Making a list will help us make the best use of our time. So you have summarized what you already know. You have communicated that this is a time-limited interaction, and elicited from the patient anything else that is important to them. You could be even more explicit about the time-limited interaction and say something such as, Jason told me that you're here to talk about your back pain today, and I had a couple of specific questions as well about that. So I'm really glad you made it in today. But before we get into that, was there anything else that you were hoping we could talk about today? I know that these 15-minute appointments go by really quickly, and you and I can start talking, and before we know it, they're over. So I want to make sure that we make the best use of our time today. So was there anything else you were hoping that we could get to today? Orienting the patient. This is 15 minutes. And then prioritize. So once the patient tells you the other things they were hoping to get to today, okay, so of the hair loss, the really gnarly ingrown toenail you have, and this boil that you have on your buttocks, what's the most important thing that we discussed today? I want to start with whatever that is after we talk about your back pain. Because I don't think we're going to be able to get to everything today and give everything its due time. And so we'll need to make a plan for the things we're not able to get to today. Right. So you are communicating to the patient, we can't cover everything today, right? I want to take really good care of you. And in order to do that, there need to be some parameters around the time that we spend on each item, right? So again, kind of bringing it all together, it sounds like this. You know, I know you're here to talk about your back pain today, and I have some questions about that too. So before we get into that, was there anything else you were hoping to talk about today? I know that these appointments are never long enough, right? And I want to make sure that we make the best use of our time. All right. So of the hair loss that you're experiencing, this toenail, this ingrown toenail that you've got, and this nasty boil that it sounds like you've developed on your buttocks, which is the most important that we get to after we've covered your back pain today? Because I want to make sure we save some time for that. I don't think we're going to be able to get to all of those things today, and I'm going to go ahead and put in a request right now for an appointment for you to come back in X number of weeks to talk about the other things. Boom. All right, and then interrupt if necessary. Really try to avoid open-ended questions. I always like to say that once you ask an open-ended question, the train leaves the station. You never know how long it's going to be before the patient starts talking again. So I already talked about kind of coming in and asking an open-ended question for answers you already have, like what brings you in today. Try much more kind of targeted questions, like what's on your list of concerns today? Is there something else you wanted to focus on, etc. So really try to limit those open-ended questions at the beginning. Open-ended questions are great when you are trying to elicit lots of information from the patient, but you don't want to do that at the very beginning of the session because, again, you don't know when you're going to be able to get to talk again. Interrupting is necessary. It is hard for lots of different reasons. We want our patients to like us. We don't want to come across as rude or disrespectful. We don't want to communicate to our patients that we're not listening to them. But what ends up happening a lot of the time is when our patients are talking and talking and talking and talking, we start to feel really anxious about how long the visit is going, and we get often very distracted by that anxiety that's building up and building up and building up. And ironically, what ends up occurring is we're so distracted by how anxious we feel and what time it is that we're actually not really listening to them anyways. So in an attempt to avoid coming across as if we're not listening to them, we're not really listening to them. So we're not really providing great care in an attempt to provide good care. It's a little bit paradoxical. So you might as well just practice interrupting so that you can do the thing that you really want to do in the first place, which is provide excellent care. So step one in interrupting is actually to attend to the narrative that you have in your mind about interrupting. What are the thoughts that you tell yourself about interrupting, and try to shift those. So if the thoughts you tell yourself are, it's rude to interrupt, my patients aren't going to like me, it's not patient-centered, try to shift that narrative a bit and tell yourself that I want to provide excellent patient care. And in order to do that, I need to have all of the time allotted to me in this visit. And I need to interrupt this patient in order to do that. By interrupting this patient, I am providing excellent care, right? So this structure, this EEE structure, came out of the University of Washington. I don't follow it to the letter, but it is helpful when you are first kind of practicing interrupting to remember the important elements of interrupting. And they are excusing yourself, so actually acknowledging that you're interrupting. Don't just jump in and ask a question, like acknowledge that you are interrupting. Empathize with the patient that what they are communicating is important to them. And then explain why you're interrupting, because what they're communicating is important. So there is an important reason why you're interrupting, right? So it sounds a little bit like this, kind of pulling it all together. Excuse me, I'm sorry, I'm going to have to interrupt you. I can tell that this situation has been incredibly frustrating, but I don't want to miss something important about your diabetes. So could you remind me, were you taking your Lantus in the morning or in the afternoon? So excuse, empathize, and explain. And then finally, the last tip that I have that I share with my residents frequently is orienting yourself to time and space. In the course of a busy clinic day, it is so easy to just get swept up in the kind of tasks of clinic and to lose complete track of where you are in your clinic day. And you don't know if you're 5 minutes behind or 30 minutes behind. So pausing just briefly throughout the day to kind of orient yourself to where you are. And what I ask residents to do is before you're walking into an exam room, to ask yourself, what time is it? What time is my next patient? And what time do I need to be out of this room in order to have time to precept, get back into the room and review the plan with the patient and start my next appointment on time? Now, that time that you need to be out of the room, it's not a hard and fast rule. It doesn't mean you get up and walk out of the room when that time hits, but it becomes an anchor for you. So as you're kind of monitoring the time while you're in the room with the patient, if you're creeping up on that time and you still haven't gotten to what your priority is of that visit, it's a little bit of a hint for you to kind of um, orient yourself, recalibrate your approach so that you can stay connected to the flow of your day. So just pause and orient yourself to time and space. And that's what I have for you.
Thank you so much, Annie. That was great.